So I really titled this talk, Progress in Prostate Cancer Grading. What I mean by that is, how can you have progress in something like cancer grading? And the answer is, I maintain that for any grading system for any cancer, you should be able to refine it and progress it to the point, using data and experience, to the point where it performs better. And that's what we're going to be talking about today and what happened with prostate cancer. And here's my disclosure at the bottom, which is not really relevant for my talk. So it's been 50 years now since Don Gleason described the Gleason grading system back in the mid-60s. Since then, we've got a plethora of data to show how it works, how relevant it is, and also its limitations. What Don Gleason was trying to purvey with his grading system was two major components that indicate a tumor's aggressiveness. One is its degree of invasiveness, and the other is its morphologic resemblance to normal prostate. So what he described here in this painting that you see over here are those tumors that are low grade, that are composed of well-described glands, individual glands, well-behaved. They have a nice rounded border, they're not infiltrative, and they're lined by cells that look an awful lot like normal prostate epithelial cells. At the other extreme, down here in his pattern 5, were tumor cells that were complete anarchists. They infiltrated raggedly as individual cells or sheets of cells. They didn't know how to make glands, and then you had everything in between. And what he also described was that prostate cancer was very heterogeneous. You often had more than one grade pattern within an individual tumor, and that's where the Gleason Score came up, and he talked about adding the most prevalent pattern and the second most prevalent. You're aware of this, 3 plus 4, for instance. What people are not very aware of is that Don Gleason himself made refinements to this over the next 15 years. His first one came in the 70s when he really defined this cut point between pattern 3 and pattern 4 a little bit better. But as you will see, even at this time, when at 1992, that's where this was published, when he had done some subdivisions, A's and B's and C's, and different patterns within these different grade tiers, what you need to focus on is right here. Where this dotted line is right here shows glands that straddle both sides of that tier. So there was a certain degree of uncertainty, even with Gleason himself, as to where these kind of morphologic patterns exist. And one of them is called the Cribriform pattern. We'll be talking about that as we go along today. But the Gleason system has performed well. What we've known in the past 20 years is that the business end of the Gleason system is in pattern 4 and 5. These are the high-grade patterns that we see. And that the relative amount of those high-grade patterns within a tumor dictates how it's going to behave. And if you look at this, this is almost 24,000 patients across 5 major institutions here, and you look at survival, prostate cancer-specific survivals in black here, you see that Gleason 6 or below tumors behave very well. And as you steadily increase the relative proportion of patterns 4 and 5, it gets worse. That's 3-4, 4-3, and 8 to 10 tumors down here. And these are the various age groups below 60, 60 to 70, and above 70. So it performs well. So the relative amount of pattern 4 and 5 is relevant. But there are still problems with the Gleason grading system that have been recognized for years. We now know, because we had tools available to us that Don Gleason didn't have, basal cell cytokeratins, etc., that show that most of his low-grade patterns that he described, those pattern 1s and 2s, were probably just benign adenoses, or at worst, were just components of a higher-grade tumor. There was confusion on how to grade these cribriform cancers. As I mentioned, there's a straddle between pattern 3 and pattern 4. Certain variants of cancer are not even described, like ductal carcinoma or small cell carcinoma, are not even described in the Gleason system. And we all know that there are problems with sampling. Small caliber needles for biopsy only sample a portion of the tumor, so they may not hit the highest grade component in there. So in 2005, the International Society of Urologic Pathologists, of which I'm a member, met to address these issues and provide some guidelines for pathologists for grading using the Gleason system. Now, it's been thought of that we met and completely changed everything there was to do about grading at that time and redefined a new type of Gleason grading system, and that's really not true. What we were doing is refining the Gleason system based on data and based on experience. And so what we're looking at is the fact that leading genitourinary pathologists from across the world got together to discuss really what their practices were and their outcomes, and compared them and said, what can we say to the community in terms of grading prostate cancer? And the first thing we did was place restrictions on assignments of very low grades, those pattern 1s and 2s, on biopsy, recognizing that some of them were benign, and 2, most of them were upgraded at the time of prostatectomy anyway, so this is probably a misleading thing. This is not something we just came up with. Long before we met in 2005, there was data from the capture system that showed that the relative amounts of Gleason patterns 2 through 4, Gleason scores in that range, fell dramatically to almost nothing over that time because people recognized this issue. We also looked at guidelines for assigning grade to Cribriform patterns. Now, some of you may have not ever heard of the word Cribriform before. Why should we care? What does that mean? That's something you pathologists should worry about. And I'm going to show you some data that suggests that we should care, that the Cribriform pattern is a specific pattern that we see that portends a worse diagnosis. And at that time, we were torn. We didn't have good data about it. So the practice was, well, let's keep those small areas of Cribriform cancer as 3, and if they're really large, irregular, and nasty looking, we'll call them 4. Not very precise and not very helpful to the community. We also discussed grading a histologic variance. For instance, ductal carcinoma got assigned to grade 4. I don't want to get into that in any depth right now. One of the more major things to come out of that meeting was how to grade biopsies. At that time, we recommended that the most prevalent pattern plus the highest remaining grade be included in the Gleason score, whether or not the highest grade was really the second most prevalent or not, so that you essentially increase the grading on a biopsy. And there was data to support this. Long before we met, back around the turn of the century, we saw data come out of Johns Hopkins that shows if you even have very small amounts, less than 5% of your tumor showed a high-grade pattern, how did it behave? If we left it out of the Gleason score and just said the basic background is a Gleason 5 or 6 tumor, but you add in even less than 5% of a high-grade pattern, it behaved worse. It behaved like a Gleason 7 tumor. And if you had a Gleason 7 tumor with a very small amount of Gleason pattern 5, those behaved worse. More like we should have put the 5 in the score in the first place. So there's data to support it. And go to the other side of the country and look at Stamey's group out of Stanford, and they said the same thing about the same time. They said, looking at prostatectomy data, what you're looking at is that the relative proportion of the tumor that's pattern 4 or 5 governs biochemical failure rates. So the higher the proportion, 4 and 5, the more likely you are to fail, even at very low amounts. So how did the changes that we looked at in 2005 affect things? This is data from Johns Hopkins again, looking at grading tumors using the 2005 modified Gleason criteria that we talked about here, and showed very good performance. If you look here, the Gleason 6s are below this top tier, and in terms of biochemical recurrence, either by grading on biopsy or prostatectomy, these have a very low chance of biochemical recurrence over 7 years, and it goes up as the relative proportion of patterns 4 and 5 increase. So here's 3 plus 4, 4 plus 3, 8, and 9 to 10s over here. Remember these tiers, these 5 tiers, because we're going to refer to them again later. And here's a multivariate regression analysis looking at it, and shows that biopsy Gleason score using the modified criteria works very well for stratifying tumors. You can see the hazard ratios go up almost exponentially as you increase the tier. Now, there were some things left unsettled, and so the ISUP met again in late October of 2014 to discuss a few more things. And in that meeting, there were 85 GU pathologists, and we invited 17 clinicians from across the world to meet at this meeting and address some of the things that were not addressed very well in the 2005 meetings. There was some clarification on these morphologic patterns and what we do with them and how they behave, particularly when grading cribriform and glomeruloid patterns. The impetus was here that we have data now to suggest that these behave more aggressively than a pattern 3. Here's what we mean by a cribriform. This is a pattern in which you have sheets of tumor cells in which there are punched out holes. They don't really make good glands individually. They make these punched out holes. And it's not clear here, but this is a large lesion because this is a lower power than here. And this would have been graded as 4 by ISUP 2005. And these smaller things in these glomerular patterns, they almost look like glomeruli of a kidney, would have been called pattern 3. But there was no data at that time to really justify that. Since then, we've compiled data. This is data from our institution that we looked at individual patterns. I think this is pretty hard to see, so I'll kind of outline what I want to show here. We looked at individual grade patterns in here, and the area in green now is the Cribriform patterns. And we did it by size, large or small, and found no difference. That these things behave badly. Here's the odds ratio, anywhere from 5.5 to 6 in terms of PSA progression over 5 years in these things. So they perform aggressively. They even outperformed Gleason pattern 5 in terms of severity. So they seem to be a phenomenon that we need to be thinking about. This is a study out of the Netherlands that also looked at this, probably more elegant study than ours. They looked at Gleason Score 7 prostate cancer, just Gleason Score 7s. And they looked at it as conventional Gleason Score 7s or those with any amount of Cribriform growth in it. And any amount was shown to have an impact on biochemical recurrence, metastasis-free survival, and disease-specific survival. You can see the hazard ratios here for any amount of Cribriform tumor there is. So the Cribriform pattern is important. It's important to mention. I think we need to start doing that as pathologists now. We need to start telling you, if you've got a Gleason 7, if there's a component of Cribriform, I think that's information you need. The other thing that really was impactful out of the 2014 meeting was an adoption of a new grade classification based upon the Gleason patterns. Basically, the question is this. In the modern contemporary era, does it still make sense to continue to use a 2 to 10 scaled grading scoring system? We know that Gleason Score 6 has favorable outcomes. I showed you the data. Yet, to the patient's eye, a Gleason score of 6 falls halfway between Gleason score 2 and 10. How can you say it's low grade? It's right in the middle. To them, it's intermediate grade. And I think that contributes to the reluctance to choose active surveillance. Gleason scores of 2 to 5 are rarely used these days and not prognostically different than Gleason score 6. And what I've told you over and over is that Gleason patterns 4 and 5, that's the money. Those are the most important things for prognosis. So what we need is some better way to relay this information to the patient so that they can make more informed decisions. So the discussion went around making prognostic grade groups. And remember those tiers that I looked at, Gleason 6 or below, could be defined as prognostic grade group 1. 3 plus 4 is 2. 4 plus 3 is 3. 8 is 4. And 9 to 10 is 5. In other words, as you progressively increase the relative amount of Gleason patterns 4 and 5, those affect the prognostic groups. This was received favorably and, in fact, voted to a 90% vote of consensus to adopt this pattern. And it be recommended that we further define the percent of pattern 4 within these categories. And all modifications to the Gleason system should be used. So it's really not a new grading system per se. It's simply using it smarter. And now there's been some validation studies since then. This is one out of Australia. It's actually multi-institutional with Australia and Canada. Looking at the different grade groupings, here's ISUP grade 1 and grade 5, and you see a progressive increase in lymph node metastases, seminal vesicle invasion, extraprostatic invasion as you go from 1 to 5. And you can see the hazard ratios for biochemical recurrence increase almost exponentially across those tiers. This is another study, multi-institutional study, looking at it in the RADAR trial, looking at outcomes over 7 years. And you saw the ISUP grade 1, there were no deaths and no metastases over 7 years if they were categorized correctly. And you can see, again, almost an exponential increase in the hazard ratio as you move through the grade groupings. And the grade groupings looked at the 2014 ISUP recommendations versus the 2005 and showed higher concordance indexes with predicted outcome for all of these, and these were significant, so that those modifications seem to be real. And at a genetic level, it's also been shown. This is Mark Rubin's data looking at the two groups. This is ISUP group 1 and 5 over here, everything in between. And you can see the relative proportion of copy number abnormalities across those tiers increases as you go from left to right, really validating that we are seeing something that's real and performs well. So I'm going to wrap up right here by saying grade is still the strongest indicator of prognosis we have. We have to use grade smartly. And the grading system for cancer to be used smartly should identify those patients who are candidates for active surveillance, mainly prognostic group 1. The Gleason grading system itself has undergone many refinements, and now the 5-tier prognostic grade groupings proposed by the 2014 ISUP meeting are based on the Gleason system. They're easily understandable, and validation studies have now confirmed clinical utility.